Did everyone get the notification that says it's recording? Awesome. Very good.
Yes.
Thank you. All right, so let's go ahead and get started. So on the first page, I have just a little bit tips for success for you guys. Really the focus of Complex Health 1. Pathophysiology was a little bit different. We always wanted to know the basic patho, hallmark signs and symptoms, how to provide patient-centered care. Now that you're in Complex Health 1, we really want to understand the pathophysiology, but really we want to hone in on our treatment, our modalities of treatment, and our nursing assessment. We always want to assess first in any sort of situations, but our assessment is not limited to just simply assessing the patient. Things such as auscultating, checking the blood pressure, checking pulse and breathing, getting an AccuCheck, checking their urine output, all of that is an assessment. So before we provide any sort of care, we want to do our assessment. What's important in Complex Health 1 is we really want to know what exactly are we assessing for in this particular disease process. Or if we don't know a patient has a condition, what assessment tools would we utilize to kind of figure out what's going on? Always assess your patient first. That's number 1. Number 2, we always prioritize ABCs and LOCs. Our level of consciousness, any alterations in mental status, etc. The first kind of little tip is that if a patient ever has an altered mental status, we're really concerned for inadequate oxygenation, inadequate oxygen getting into the brain. So we always want to assess that. And as always, airway, breathing, and circulation. Prioritize your care. Always ask yourself, how would I do this as a nurse? Knowing your lab values and your medications, those are very important, especially the lab values. This exam is pretty heavy on your lab values. So I really recommend whether you do flashcards, etc. Unfortunately, those are just things you're going to have to memorize, and you're going to need to know them for the rest of the program as well. So let's begin. Let's start with endocrine first. So, diabetes. We all know the very basic differences between type 1 and type 2, which we'll go about in the next slide. But here's going to be the lab values you're really going to want to focus on. We really want to focus on number 1, their HbA1c. Usually our patients know that they are diabetic, and therefore they're going to seek their treatment for their diabetes. What we're going to want to do, though, is monitor their HbA1c levels. These really indicate how well they're managing their diabetes. So it manages blood sugar every 3 months. So he's going to provide values. We just need to know what it means if it's high or low. Okay, awesome. I know when I took the class, we weren't provided all the lab values. So if he provides them, great. I would also have them memorized just in case. So our HbA1c, like I said, they really monitor how well we've been managing our blood sugar over time. One singular AccuCheck is not going to tell us if we have diabetes or not. Who knows? Maybe I just ate a candy bar right before taking, my blood sugar, and now it's really high. That's not going to prove that I'm diabetic. So that's why we really want to look at our HbA1c levels. Really knowing the differences between hypo and hyperglycemia and how we're going to assess that, that's going to be very important because, again, those are our complications of diabetes that's not being managed as well. So type 1 versus type 2 diabetes. When we have type 1 diabetes, that's going to be our autoimmune disorder, although it's not always present at birth and it can develop over time. But the main thing to know, this person produces no insulin. What is our function of insulin? Insulin is a key, if you will. It is the key that unlocks our body's door. So what I mean by that is our body needs carbs. It needs sugars. It needs all of that in order to function. It's a major macronutrient. But without insulin, physically, our body cannot absorb sugar. So that sugar keeps building up in our bloodstream and it stays there, which is not good. That's what's going to make your patient hyperglycemic. And then they're at risk for DKA and things like that. So without insulin, there's no way that these patients can intake the carbohydrates, the sugars. So that's why they're going to present with those weight loss in the beginning, because they're missing a major macronutrient. Again, they're going to have that polyuria, polydipsia, polyphagia. Why? All that blood sugar is piling up in the blood. The body wants us to consume more water so we can try to flush it out. Treatment for this is going to be insulin. So review your types of insulin, what insulin can be mixed versus what can't be mixed, what you want to look out for, especially our Samogi and our Dawn phenomenon. But again, those were all covered in pharm, so I'm not going to cover those too much. Whereas our type 2 diabetes, think lifestyle considerations. These are really due to chronic ingestion of high sugar, high fat foods, etc. So teaching our patient who is at risk for type 2 diabetes or who has type 2 diabetes, we really want to educate them on risk factors and how to prevent that. And really, it's just going to be our lifestyle changes. So our metabolic syndrome, that is when someone has those increased blood glucose, increased triglycerides, hypertension, and abdominal obesity. So those are going to be your risk factors. So diabetes, again, review your types of insulin, review your metformins, but really what we're concerned about is our complications of chronic diabetes. Complex Health 1 focuses on your chronic diseases and your chronic disease processes. So unfortunately, there's a lot of complications to diabetes, but in specific, we're really concerned about our diabetic retinopathy, neuropathy, nephropathy, and our episodes of sugar imbalances. So what we're going to focus on as nurses is we really want to monitor our patient for signs of systemic uncontrolled high blood sugar. I don't know if anyone in the clinical setting has seen a patient who's been diabetic and has went to go taking their socks off for checking pedal pulses, and it's like a flurry of snow. That's going to be your diabetic neuropathy. They have very minimal feeling in their feet. They don't get a lot of adequate blood flow to their feet. So educating your patient on proper foot care is going to be a very, very important thing. Making sure that they put lotion on their feet, but not in between their toes, making sure they frequently check their shoes, that they're not walking around barefoot all the time, that if they have a sore, that they go to the podiatrist. You're going to be the ones teaching your patient these things, so I really recommend focusing on that. Additionally, you want to teach your patient on their sick day education material, which is covered in your textbook. There's going to be a chart on that. Something like that looks like, even if our patient is sick, we still want them to take their insulin, even if they're not eating as much because they don't feel good. We want to encourage them to keep taking frequent snacks, and we really want to have them do their blood sugar checks as well. Again, educating them on those lifestyle changes. Those are going to be what's really important for our diabetes and our diabetes management. Now we get to cover cardiac. I really enjoy cardiac, but I know it can be very difficult. So I have a couple slides just reviewing your cardiac medications. Again, I'm not going to spend too much time on these because they were covered. Just really recognize our calcium channel blockers. What are they? They are very nice drugs, VND, verapamil, nifedipine, and diltiazem. Our ACEs and our ARBs, ACEs end in pril, ARBs end in sartan. All of these medications aim to lower our blood pressure and improve our cardiac output. Again, we have our nitrates and our cardiac glycosides. These are our positive inotropes. These are really what we're going to be using in those critical cardiac situations, such as our myocardial infarction, angina, etc. Again, always remember your hallmark side effects. I think it's very important to know the signs and symptoms of DIG toxicity and how to monitor that. Again, beta blockers, they're really used for our hypertension, angina, arrhythmias, MIs, etc. Again, they just work by promoting vasodilation and lowering the blood pressure. And we're going to talk about why chronic high blood pressure is going to be very bad. Heparin and warfarin is a big one for this semester, so really know your lab values for these. Knowing what is our therapeutic range for heparin, what's our therapeutic range for warfarin. Can my patient go home on heparin? No, they can't. They can't go on a heparin drip. They have to be switched to warfarin. And knowing that warfarin takes a little bit of time to work, so before I can put my patient on warfarin, I need to start them on heparin. Why? Because heparin works right away. But we really want to opt for a safer form of warfarin. That's going to be our Lovenox shots that we give in the belly, or our low molecular weight heparin. There's less risks of injury for that. Really, heparin and warfarin are big ones. So I also included some cardiovascular equations. I think they're important for you guys to know as well. Knowing our pulse pressure, why it would be low, why it would be high, widened, knowing blood pressure. Our MAP is really important. You might have a few questions where it asks you to calculate these things. So just having them there is important, because I do remember we had a few questions where we did need to calculate our patients' MAP, and we had to kind of decipher what their pulse pressure was. So again, our MAP, that's how well we perfuse our organs. Again, you're going to use whichever equation you prefer. Both the top or the bottom will give you the correct answer, and you guys have this sheet for you. But really, it measures how well we perfuse. It's highly influenced by our cardiac output and our systemic vascular resistance. That's how healthy is my heart? How well is it toned? Is it okay? Is it weak? Do I have a pump problem, etc.? Pulse pressure, that's going to monitor also the health and tone. Really, that's what we're going to use to determine if someone's at risk for some cardiac disease. And then finally, blood pressure, which we're going to talk about, I promise. Final equation I have for you guys is our cardiac output. This is how much blood we're sending out to the body. Again, knowing our normal cardiac output's important. I know on the PCW, there was like a practice graph. I think that works really well. But here's just a basic kind of overview of our cardiac output. And the whole purpose of having a good cardiac output is also how well we're going to perfuse. The only way to get oxygen to our organs is through our blood. How do we give blood? We pump it through the body. So we really want to make sure our cardiac output stays within our normal range as well. Ejection fraction, that's just how much blood leaves the heart each time it contracts. And this is really important when we begin to talk about heart failure with a preserved ejection fraction or a reduced ejection fraction. So just keep that in mind. You guys have all these equations for you. Hypertension, again, this is kind of knowing your normals. Really, our major risk factors for hypertension, those are just lifestyle changes, specifically weight and diet. So when we're teaching our patients how that they can avoid hypertension, we want to make sure that we run a cholesterol panel on them just to see what we're working with, to see if maybe diet's a contributing factor. If we have elevated total cholesterol, triglycerides, LDL, that put the patient at significant risk for hypertension. Also, know what your BNPs are. What in the world is BNP? Basically, BNP is a hormone that is secreted when our heart is stretching, when our heart is under excess stress. So just think BNP stretching. Why would our heart stretch? Well, if we have increased blood volume from high blood pressure, that's going to be a big one. So the higher my patient's BNP is, the more that they are having these issues of high blood pressure. And just knowing our hypertensive crisis is something we need to look out for, because if someone's having a hypertensive crisis, there's no way that they can adequately perfuse. So again, hypertension are essential. That's going to be most common, and really, we can't pinpoint an exact cause. It's linked to those lifestyle changes, those lifestyle factors, the obesity, diet, etc., lack of exercise. Our secondary, that has a direct cause. If anyone wants to provide an example of what a secondary hypertension might be, shout it out, put it in the chat. Our malignant, that's going to be our hypertensive crisis. But is there anything you guys can think of that might increase a patient's blood pressure? So think about what is blood pressure? How is it? What factors contribute to that?
Can stress be a factor?
Stress can definitely be a factor because we're activating our body's fight or flight system, which releases, it goes back to our ADH, our aldosterone. It's going to hold on to fluid. That's our main thing. So like Sarah said, fluid overload. Whether someone has SIADH, that's going to increase their fluid. Pregnancy-induced hypertension, that we can link to a secondary cause. Whereas our diet, that's going to be usually our essential hypertension. So again, number one risk factor is smoking. So review your smoking cessation. That's a little tip for this exam. If there was any questions to come up, it's probably going to be our smoking cessation because I think that's very important for cardiac health. Again, diet, family history, etc. Unfortunately, with hypertension, there's not a lot of causes, so many patients go undiagnosed, and until it gets very serious or very critical, we don't really know that they have it because it depends on serial readings. But unfortunately, this lack of oxygen to the tissues will result in organ failure. So I do have this grouped out a little bit easier for you guys to kind of see what's going to be our medical treatment. We're going to give them their ABCDs, their ACEs, their ARBs, their beta blockers, their calcium channel blockers, diuretics to help get rid of that extra fluid if our issue is fluid overload. Why? Excess fluid creates just more blood, and that's more stuff that our heart unfortunately has to pump out. So some nursing interventions, just review how you would take. Would you mind repeating what essential and secondary causes of hypertension are? Of course. Let's go back. So when we have essential hypertension, we cannot pinpoint a cause, but this is our quote unquote traditional hypertension linked to a diet high in saturated fats, obesity, inactivity, family history. We say that it's an unknown cause because we can't specifically pinpoint any of these. We can't attribute it to any of those risk factors. Whereas secondary hypertension, it has a known cause. That's going to be pregnancy-induced hypertension. If someone has syndrome of inappropriate ADH, that's what's causing their hypertension. We can specifically link that. So that's how you kind of differentiate. But just think essential, unknown cause, risk factors. Where secondary, we know what it is. Awesome. Back to our nursing interventions, know how to appropriately take your patient's blood pressure, making sure that their legs are uncrossed. If your patient is on a diuretic, doing those I&Os, we want to know, are they holding on to the fluid? If they're holding on to fluid, I'm concerned that they're going to have a high blood pressure. Really honing in on that patient education. Exercise, healthy BMI, encourage them to follow their DASH diet. Those are your dietary approaches to stop hypertension. So basically, it's kind of like your vegetarian diet, your fresh fruit, no aged meats, no aged cheeses, nothing you would find in a pantry, just things like that. So review the DASH diet for that. So coronary artery disease, this is the buildup of plaques on the coronary arteries. This really does lead to almost any cardiac issue, whether it be an MI, possible stenosis. Coronary artery disease really isn't, quote unquote, a disease of its own, but it's really, really bad and has a very bad prognosis for the development of future cardiovascular issues. So just for this one, we know that it's usually caused by, again, our diet. So making sure we review what our patient's lipid levels are is going to be really important. and knowing how to educate them for their diets. So essentially what happens is the more these plaques build up, the narrower and narrower the artery gets. So blood flow really just can't go through. And if blood can't go through our heart, then it can't go throughout the body. And unfortunately, we're very nervous that these plaques could possibly break off and lodge somewhere else, reduce blood flow, etc. So educating your patient on a heart-healthy diet, smoking cessation, weight reduction is going to be really important because we don't want these plaques to burst. So our chronic stable angina, this is usually linked to our coronary artery disease. Unfortunately, coronary artery disease is the #1 cause of both stable and unstable angina and our MIs. But really how we differentiate CSA is that we have a familiar pattern of this chest pain. It's going to go away with rest, or it's going to go away with nitroglycerin tablets. The patient really is familiar with these. So we're okay for now, but we're concerned that it's going to progress to unstable angina. So we really, really want to make sure that we address these modifiable and our non-modifiable risk factors. Smoking and alcohol use, cut it out. We really want to reduce those lipids, triglycerides, etc., because we want to stop it from progressing to prismals or unstable angina. So again, they might present with dyspnea, dizziness, fatigue, but you always want to assess your patient first. So I included some lab values on the side. Those are just really not super important, but in case you were interested in cardiac, I like to include those for you because I know I'm really interested in cardiac. So up next, we're going to talk about our MI, our myocardial infarction, and that's really important. Excuse me, let me go back. In understanding really what we're going to want to do in terms of treatment. So all of our treatment is going to aim to prevent a myocardial infarction. So what are we going to do? Back to our ABCDs. We're also going to give our nitroglycerin because it helps promote vasodilation, making sure these patients are on antiplatelets, aspirin and Plavix. Why? Because we want to make the blood easier to get through these really clogged, really narrow walls. For this one, a big medical treatment is your cardiac catheterization. So our nursing considerations are really going to be based around cardiac catheter. So really reviewing everything you need to know in order to do that, knowing that you need to get their patient's consent. You have to verify them for any allergies. Do a medication reconciliation. Have they taken metformin? If so, we need to hold it because metformin works on the kidneys. Iodine is harsh on the kidneys. We're concerned for an acute kidney injury, which is not good. After their cardiac cath, you really want to do frequent assessments on your patient. You want to look for any bruising, any bleeding. If I had an incision or I went into a vein, I want to check the pulses distal to that. Why? I'm concerned. What if a blood clot happened? What if when I was pulling out my needle, a piece of it got stuck and now that whole vein is occluded? So that's why we're going to want to really make sure that we check those distal extremities. If you can't find a pulse, get a Doppler. And then really keeping that extremity straight for 6 hours. Again, knowing your patient education, if they're going home on these meds. I'm not going to spend too much time on that, but just the ED meds, how to take their nitroglycerin, lifestyle modifications, etc. So what happens if we don't fix CSA? It can unfortunately progress to an MI. So a myocardial infarction occurs when our heart muscle doesn't get enough oxygen and it begins to become ischemic and necrose. This usually takes around 6 hours to develop from the onset of symptoms. So that's why we really want to get these patients to the hospital because they're going to need advanced medical treatment. And really, #1 risk factor, coronary artery disease. So what are we going to do? Educate our patient on how to prevent coronary artery disease or its progression. So let's talk about our cardiomyopathy. So this is what happens when the heart's just had to work overtime. Usually it's a consequence of chronic hypertension. That heart has to work extra hard. Think about the heart's a muscle. If I go to the gym and I work out my muscles extra hard, I'm going to get big, I'm going to get strong, but I'm going to get less flexible. Why? Because of all that muscle. The same thing with the heart. The heart's going to get bigger, it's going to get stronger, but not necessarily in the way we want it to. This is what happens with cardiomyopathy. So the heart muscle becomes so enlarged, so thick and stiff, it simply cannot have that adequate squeeze anymore. It's lost that elasticity. What's going to happen? Heart failure, poor cardiac output, poor perfusion. So why are we concerned? We're concerned because cardiac output, no oxygenation, organ failure. So again, I would just review the basic definitions of dilated, restrictive versus hypertrophic cardiomyopathies. Again, very, very basic definitions. And knowing what our risk factors are, the myocardial damage, chronic hypertension, possible genetic link, rheumatic fever, things like that. But really, for the purposes of this course, what are our modifiable risk factors we can focus on? So what are our signs and symptoms of inadequate oxygenation? That's what we're going to assess for. Is my patient's mental status changed? Are they now anxious? Are they mad at me all the time? Can they not sleep? I'm concerned about heart failure, so assessing for signs and symptoms of heart failure, which we're going to get into, etc. So what are our lab values? They can have that elevated BNP. Why BNP? That's our stretching hormone. So if I have excess BNP, I know that my heart has extra stretching going on. Not good. You can do a chest x-ray, cardiac cath, MRI, but really our gold standard is going to be our echocardiogram. And our echocardiogram, that looks at ejection fraction, backflow, is there any valve problems? So really important. Again, ABCDs. Unfortunately, that's just what we do for cardiac treatment. We're either going to do our ABCD meds or we're going to have to do surgical repair. Whereas opposed to our specific disease processes, they have very specific medications. Cardiac doesn't, because cardiac is kind of a wide range of things. But if we think about it, like I said in the beginning, almost all of our cardiac disorders are caused by CAD. So a lot of these medications work to not necessarily treat CAD, but treat the symptoms associated with it. That's why all these medications are used for almost every cardiac issue. So know your medications, know what to look out for in the certain medications, etc. So if your patient has cardiomyopathy, we really want to make sure that before they leave, they've had an echocardiogram and they've been placed on an ACE or an ARB. That's your gold standard. Again, education is super important. You want to assess those signs and symptoms of heart failure. That's why we do our strict INOs in daily ways. Why? A patient with cardiomyopathy is at significant risk for heart failure. And one of the first signs and symptoms of heart failure is these patients will have fluid overload, weight gain. So we're really concerned. So really telling them, if you notice your shoes aren't fitting or your clothes aren't fitting and you've gained weight daily ways, and now all of a sudden you've gained 2, 3, 4, 5 pounds, call your provider. And then really doing your MOD self-management, medication, activity, weight, diet, symptoms. So I included this for you guys. It's a good diagram of blood flow through the heart, just in case anyone's struggling with this. Really, I'd say focus on knowing that the ventricles are what pushes the blood somewhere. Is the 2 to 3 pound gain a week or a day? It's in one day. So they've gained 2 to 3 pounds in one day. Awesome. So our blood flow through our heart, atrium kind of collects the blood, our ventricles push them out somewhere. That's something I like to kind of remind myself of when I get confused. Specifically, when we talk about our valve disorders, kind of knowing where's our mitral valve and where's our aortic valve. helps a lot too. But again, you guys have this. It's up for you guys. I tried to make it as simple as I could to help out. So let's talk about left-sided versus right-sided heart failure. And this is kind of also where the diagram of blood flow helps. So anytime a patient has left-sided heart failure, it can lead to right-sided heart failure. And I'll get to that in a moment. But when we think of our left-sided heart failure, the left side of the heart pumps the blood out to the body. It receives blood from the lungs. So if there's any issue with the left side of our heart, not only can we not pump it out to the body, but it's going to get backed up into the lungs. So that's why our symptoms are drowning in fluid. So they're going to have that pulmonary edema, crackles, pink frothy sputum, orthopnea, fatigue, tachycardia, pulmonary congestion. What are we concerned about? We're concerned for cor pulmonale now. So that's kind of the patho of left heart failure. Right heart failure, what's the right side of the heart do? It takes blood from the body and sends it to the lungs. If my right side of my heart can't do its job, not only can it not effectively give that blood to the lungs, but eventually it's just going to back up back into my systemic circulation. So that's where it rocks the body with fluid. So it's usually precipitated by our pulmonary hypertension, our cor pulmonale. So again, fluid backs up into that venous circulation. So my patient has edema, JVD, all my organs, I should say, are enlarged because the blood's got to go somewhere. It's just going to deposit in our organs. So that can also impact our organ function. So fatigue, weight gain, again, that 2 to 3 pounds in one day, really concerned. So I would just kind of remember what's happening. But the reason that left-sided heart failure can lead to right-sided heart failure is that if the left keeps sending it back to the right side of the heart not only has to work harder to accommodate this extra blood that it keeps receiving, but it also has to work extra hard to try to push that back. So again, same concept, weightlifting, great for sports, horrible for the heart. When the heart gains muscle, it's not going to work as well as it should. We need it to be flexible, not hypertrophic. So HREF versus HPEF. Heart failure with our reduced ejection fraction or heart failure with preserved ejection fraction. Main thing for this, look at the patient's ejection fraction. This is how we differentiate systolic versus diastolic heart failure. So when we have systolic heart failure, the heart can't effectively squeeze. If it can't effectively squeeze, it can't effectively shoot blood out into the body. It can't effectively shoot that blood out so that we can get the blood that our body needs. Therefore, my ejection fraction is going to be reduced. Why? Because I'm not pushing out blood. If I'm not pushing out blood, my ejection fraction goes low. Why? I'm not ejecting a lot. When we have our diastolic heart failure, this is usually caused by our chronic hypertension, but the valves are thick, rigid, and stiff. They can't relax to fill up. There's a problem with filling. There's not a problem with ejecting. So our patient will actually have a normal ejection fraction. It just might take a little bit longer to fill up. It might not be as effective as filling, but they're still putting it out to the body. There's not a squeeze problem yet. So that's why in diastolic heart failure, they're going to have a preserved ejection fraction. Why? The valves close during diastole to fill. So during diastole, I'm not sending anything out to the body. That's why they have that preserved ejection fraction. So if you kind of understand your basics of systole versus diastole, that's how we know diastole has a preserved ejection fraction. If we have systolic heart failure, we can't have a preserved ejection fraction because there's an issue with sending the blood out. That's what happens in systole. So that's another way of kind of understanding that too. So I broke it up in half for you guys. Let's start with left heart failure. So when we have left systolic heart failure, these patients will have, again, a reduced ejection fraction because it's a systolic issue. So blood left in the heart after systole eventually just backs up into the lungs. This is what gives us that left-sided heart failure signs and symptoms. So we're taking the basics of left versus right heart, and now we're applying it to patient situations. If we have left diastolic heart failure, we will have that a normal ejection fraction. Why? If it's a diastolic issue, it has a normal ejection fraction. So these patients will have a normal ejection fraction, but still be showing those signs and symptoms of left-sided heart failure. Right-sided systolic heart failure, again, I'm drilling it into your brain, systolic is reduced. So the blood left over from the right side of the heart is not going to be able to go through the heart and go through the body. So they're going to have that reduced ejection fraction, but where does the blood go in right-sided heart failure? It backs up into the body. So they're going to have those engorgement, the ascites, etc. If we have right diastolic failure, we're going to have, again, our normal ejection fraction. Why? Because it's occurring during diastole, but they're still going to have that right-sided heart failure signs and symptoms. So I hope that helped a little bit for that. If I'm going too fast, just put it in the chat. We just have a lot to cover. Again, back to our treatments, ABCDs. Again, this is the exact same slide as the cardiomyopathy slide. Why? Because you treat it the exact same, because most often cardiomyopathy is what's going to lead to heart failure. So treatment's going to be the same. So valve disorders. I know valve disorders can be a little bit tricky, and that's why I did update these slides. The slides from the PDF you guys received, the only slides that are different are these 4 slides about the valve disorders, just because it's very confusing and I wanted to make it as digestible as possible. So really pay attention to the mitral valve and the aortic valve. Don't focus on the pulmonary valve. I just thought it was important side information, but for test purposes, I wouldn't worry about that. But look at where a mitral valve is. It is in between the left atrium and the left ventricle. If my mitral valve can't close, my left atrium will eventually fill up and back up into the lungs. If my mitral valve keeps opening while my blood is in the left ventricle, then I have less blood leaving the left ventricle out to the body. So that's just like a broad overview, a broad concept of our mitral valve. And we know our aortic valve, that's our big pumper. It pumps the body with blood. So we separate them into 2 categories. You have your stenosis and you have your regurgitation. Stenosis, that's our thick, that's our stiffening. Our heart, our valve has had to work extra hard and it's hypertrophied because of it. So therefore, it's going to become thick and stiff. It can't open. Anything that damages the heart can cause stenosis, cardiomyopathy, wear and tear, certain rheumatic fever, if someone has a history of rheumatic fever, etc. Regurgitation, on the other hand, this is when our valve has a problem closing. If it can't close, blood can seep back in and go back to where it came from, which isn't good. So there's an incomplete closure. So let's talk about our aortic valve. Remember, our aorta carries oxygenated blood away from the heart into systemic circulation. It closes during diastole. So what happens with this? With stenosis is our aortic valve's not going to open. This results in poor perfusion because all that blood can't get out to the body. So what are complications that can arise from it? Well, we know this is an issue with the left side of our heart, so it's putting our patient at risk for left-sided heart failure. Additionally, they're going to have poor perfusion and low cardiac output. Signs and symptoms, they're going to have that chest pain, syncope, dyspnea. All of that are signs and symptoms of poor perfusion. Specifically with aortic valve stenosis, though, we're going to have a systolic murmur. We're going to have a low blood pressure from poor cardiac output. And with tachycardia, our heart rate's going to try to increase to compensate for the low blood pressure. So what do we do to treat? ABCDs, anticoagulants, and possible valve repair if the patient qualifies. Something for nursing considerations, I would highlight your assessment. So in this case, what is our assessment? Our assessment is going to be our auscultation. Not only are we going to be looking at signs and symptoms, but really know what am I looking for. In this case, what am I listening for? I'm listening for a systolic murmur. Where am I going to listen? Second intercostal space, right of the sternal border. So that's what I would focus on just for the purposes of this disease process. When we have our aortic valve regurgitation, this is a problem with closure. So the blood is just going to back up into the left ventricle, again, putting the patient at risk for left ventricular failure and left-sided heart failure. However, there's still a good amount of blood going out to the body. So right now, perfusion is not my utmost concern. I'm concerned for the development of heart failure. So signs and symptoms for this, they're going to have tachypnea, dyspnea, fatigue, tachycardia, all of it just because our heart has to work a little bit extra hard. They're going to have a widened pulse pressure. Why do we think that's the case? Well, think about a very basic concept of the amount of blood in doesn't equal the amount out. So in systole, I'm, filling and producing a lot, but during diastole, the amount just doesn't add up. That's why they're going to have a widened pulse pressure. So again, for this, I would know, where are we auscultating? Third intercostal space left of the sternal border. We're going to hear something during diastole. So again, really just memorizing that. If I'm doing my patient assessment and I hear that, what's that indicative of? So our mitral valve. We talked about in the picture, the mitral valve is what's separating the left atrium from the left ventricle. From the left ventricle, it goes to the aorta and out to the body. So if I have mitral valve stenosis, my blood gets stuck in the left atrium. Well, the left atrium is going to back up into the lungs. So it's going to back up into that pulmonary circuit and can eventually lead to right-sided heart failure like we talked about earlier. So what are our complications? We're concerned about a mitral valve prolapse, and we're concerned about our decreased cardiac output. Our signs and symptoms for our mitral valve stenosis are going to be pretty indicative of right ventricular failure because all of this blood is pumping back through the lungs, back to the right side of the heart. So what are they going to present with? They're going to have fatigue, orthopnea, JVD, pitting edema. So again, treatment for these, we have our medications, but we also have our valve replacement treatment, which is really good. For this, I would know the differences between our biological and mechanical valves, really reviewing which one lasts longer, which one has more risks. Does my patient need to be on any certain medication if they have a mechanical valve? Just reviewing those things I think are really important. And if you have any questions, just put them in the chat and I'll be happy to answer them. For this one, our nursing considerations, assess for that diastolic murmur at our PMI. How do we locate our PMI? Review that. When we have our mitral valve regurgitation, on the other hand, again, not as serious as our stenosis, but has different signs and symptoms. So with this disease process, blood is going to leak back from the left ventricle into the left atrium. So again, not all of that blood is going out into systemic circulation, which isn't ideal if this is a chronic issue because it means that over time our body is going to get used to getting less oxygen. It's going to sacrifice organs, etc. So for these, I just know our complications. We're concerned for organ failure. Why? Our body's just going to eventually our body's going to get really tired of not getting enough oxygen pretty quick. Again, backflow of blood. We're concerned about atrial fibrillation because all of the blood from the left ventricle can leak back into the left atrium. The left atrium gets irritated, etc. Again, signs and symptoms pretty similar: edema, ascites, organ enlargement. But for any of our regurgitation issues, they can get an annuloplasty done, which is going to be a ring that really reshapes the heart valve. So what are our nursing considerations? We're going to oscillate at the PMI for a systolic murmur. If my patient's progressed to heart failure, we want to fix all of those modifiable risk factors and slow the progression. Because these patients are usually on anticoagulants, I'm going to monitor their INR for warfarin and make sure it stays within that therapeutic range. So, restarting the heart, defibrillation versus cardioversion. Not going to spend too much time on this, just knowing defibrillation. This is done on our dead patient. They have no pulse. We need to give them a pulse. So what are we going to do? We're going to do CPR. Review your rate, rhythm, depth, where we're placing our AED pads, and know that defibrillation depolarizes the heart. What occurs is that we shock all of the electrical activity outside of the heart. Why? For some reason, the patients went into cardiac arrest. Cardiac arrest is the heart's way of saying, I am overstimulated, I'm freaking out, I need space, leave me alone. It got overstimulated and it's not working anymore. So the point of defibrillation is to shock all that electrical activity out so the heart can rest, it can recoup, and it can move forward, and hopefully put them in normal sinus rhythm. But in order to do so, we need to give the patient some sort of pulse. How do we do this? Through CPR. So defibrillation, again, can be used on a patient with no pulse or a patient with a lethal rhythm, VFib and VTAC. However, if they don't have a pulse, we do need to give them a pulse. So you can't shock on asystole, but if we're giving CPR, we can hopefully put them in VFib or VTAC. They're not going to have technically a pulse per se, but they're still going to have a rhythm that the AED can shock. A little photo. Our cardioversion, on the other hand, this is done on a person who is alive. They're awake, they have a pulse, it's done under conscious sedation, usually used for rhythms that aren't favorable, but usually they're done on irregular rhythms in which the patient is symptomatic. Not always will our patient be symptomatic if they have an irregular rhythm. It might just be normal for them. But if a patient's having chronic symptoms and they're really just, we can tell that this isn't good, or, you know, they're satting not as well as we would like, this is when cardioversion could be an option. Is mitral valve regurgitation a systolic or a diastolic murmur? Mitral valve regurgitation is going to be our systolic murmur. So back to cardioversion, no problem. What are we going to do? Give them their meds, digoxin, calcium channel blockers, beta blockers, all of which act to calm the heart. Really, we're going to monitor our patient for clots, give them heparin and warfarin, and go from there. I have a little slide on ICDs. I would recommend reviewing what happens when they don't work. If my patient has an ICD, maybe my patient just got discharged and they have a brand new ICD. What am I going to do? I'm going to explain to them post-procedure protocol, keep your arm in a sling, minimize movement, etc. Also, we're about to go into EKGs. I would just kind of, because we're already talking about EKGs, just review what happens when an ICD is having failure to sense, failure to capture, and failure to pace, because those might possibly be testable material. So, EKGs. Review your normal sinus rhythm. This is pretty much all I can say for that. Dr. Rosales usually gives you 6-second strips. That way you don't have to worry. If you're trying to calculate heart rate, you don't have to worry about excess math. So just to put your mind at ease a little bit, when we're calculating heart rate, we're going to count the amount of R waves in a 6-second strip and multiply by 10. I would know what are our normals. I listed them on the right for you guys. Again, you have this slide, use it to your advantage, practice, etc. But each really tiny square is 0.04 seconds. Each group of 5 squares, that's going to be 0.2 seconds. 5 blocks is 1 second. And usually they will have like a bolder line grouping 5 big boxes together. So that's going to be really important in helping you determine what rhythm is what. Because how do we differentiate rhythms? Well, they're not going to look like normal sinus. They're not going to add up. They're not going to have the same values. So now we're going to review EKGs. So I have it laid out to where first you guys are going to see this rhythm and put in the chat what rhythm you think it is and what might be causing it. So what do you think it is and what's causing this rhythm? Yes, this is our sinus tachycardia. So the first thing we always do when we're at a rhythm, do I have, for every P wave, number one, do I even have a P wave? If I have a P wave, do I have a QRST complex? In this case, we have a P wave, we have a QRST complex, but let's count the heart rate. This is a 6-second strip. We'll pretend that this is a 6-second strip. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 R waves. 13 times 10, 130. My patient's heart rate is 130. So this is our sinus tachycardia. Awesome. So usually caused by our fight or flight, can be triggered by many things: anxiety, caffeine, certain medications, epinephrine, etc. Everything else is normal, just our heart rate is a little bit elevated. What's our treatment? First, you're going to get real tired of me saying this, but assess your patient first. You see this on the monitor. What am I going to do? Well, first of all, I'm going to go assess my patient. I'm going to make sure they're fine. Are they short of breath? Is their pulse ox giving me a good reading? Is it above 95? Are they doing okay? And then you move from there. So, again, assess them for shortness of breath, dizziness, decreased blood pressure, and really address the underlying cause. If they're anxious, use therapeutic communication. You can also give beta blockers, etc. All right, so what do you guys think this one is? So first thing I do I have a P wave for every QRST complex? I don't think so. I don't think so. I don't know if it's a P wave, is it a T wave? I'm not sure. So yes, this is our atrial flutter, usually going to be caused by coronary artery disease, heart failure, hypertension, etc. Heart rate's usually going to be between 75 and 150, and it has that characteristic sawtooth P wave. We're unable to determine what our PR interval is because I can't really tell where my P wave is. Is it a P wave? Is it a T wave? What's going on? So what do? Assess my patient. Some things I want to look for: are they short of breath? Do they have a low blood pressure? Are they fatigued? Do they feel faint? What are we going to do? And how do we treat it? Well, we're going to want to give some medications, possible antiarrhythmics, anticoagulants, possible cardioversion, etc. What's this? This one's a little bit confusing. What do I do if I'm sitting at the nurse's station and my patient on telly shows me this? Yes, this is artifact. So what am I going to do before I run into my patient's room?
Check that they have a correct placement of like the stickers.
Yes, awesome. Very good. So yeah, I'm going to assess my patient. Are my electrodes on right? Check my leads. Maybe my patient just got up and is brushing their teeth, moving, dancing, doing their own thing. I'm just going to check them, go assess them, make sure they're doing okay. Perfect. So what do you think this one is? I know it's a little bit tricky. If you can kind of see, I did circle something I want you guys to look at, and that might also help determining what this is. Do I have a P wave for every QRST complex? So this one's not first-degree heart block, but I can see why you would think that, because where I see my little circle, there's something going on and I seem to have that prolonged phase. But this is our normal sinus rhythm with a PAC. So as this rhythm's going, I see P, QRST, P, QRST. And then right around when I get halfway, I see a P, QRST. And then to me, what looks like T, QRST. That's what it looks like to me. I can't differentiate if that's a P wave or a T wave. So this is a PAC, meaning our P wave comes a little bit early and ends up hiding in our T wave. So this usually occurs when the atrial tissue becomes just aggravated. Think of all the ways that our atrial tissue could become aggravated. Nicotine, caffeine, stress, anxiety, infection, substance abuse, drugs, amphetamines, all of that. So my PAC became irritated. So of course, I go and I assess my patient first. Because they might not even be symptomatic. Some might say, oh, I just felt my heart skip a beat. They might say that. But if my patient is in normal sinus rhythm with a PAC, I need to make note of that because I need to look at trends. I know Dr. Rosales talks to you a lot about trends. That's one of the most important things to know. How long has this been happening? But why am I concerned? It's just one PAC. Well, what if I assessed my patient, they have one PAC. Then 15 minutes later, they're throwing 3 PVCs in a row every 2 minutes. Is the previous example normal sinus rhythm with a PAC? Yes, that example was normal sinus rhythm with a PAC. We're still talking about that. But with your PACs, I can't stress this enough, monitor the trends. Because one, every now and then is fine, but I'm concerned if this keeps happening again. Because if my patient keeps throwing PACs, I'm concerned for dysrhythmia. The heart rate shows 110. This might not be a 6-second strip. I couldn't find 6-second strips for all of these. This one should be around like 90 beats per minute if it were a proper 6-second strip. But yeah, not all of these like are perfect 6-second strips. Dr. Rosales, though, will give you perfect 6-second strips. So again, with your PACs, this is normal sinus rhythm with a PAC. Really focus on your trends. How often are they throwing these PACs? What about this one? Let's pretend that this was a 6-second strip. If this was a 6-second strip, what would this be? Do I have a PQRST? Do I? That's where you start. Yep, so this is our sinus bradycardia. I have a P for every QRST complex. So what am I going to do? I'm going to assess my patient. I'm going to go check on them. Are they doing okay? Because guess what? This might be perfectly normal if my patient is an athlete. This might be their normal. Possible causes in which we would be concerned. If my patient has increased ICP and they start losing control of the respiratory control center in the brain, they might become bradycardic. So just really kind of assessing my patient. If my patient is in SVT, they're tachycardic, and I tell them to bear down, do their Valsalva maneuver, this might happen as well. But if this is a case where this is not normal for the patient and they keep trending downwards, what am I going to do? They might need an ICD for pacing. Unfortunately, what we've been noticing, especially within an eating disorder community in clinical settings and psychiatric settings, is our patients with chronic anorexia or chronic bulimia nervosa, their heart can't function anymore, so they're constantly bradycardic, and they actually end up requiring ICDs. And what do? Those are going to provide pacing. They're going to have a set rate. If your patient's heart rate drops below, let's say 50, it's going to deliver a shock to start that complex again. Also, if this is in an emergency setting, you're going to administer atropine for this patient. So what do you guys think this one is? What looks weird? Do I have a P for every QRST complex? Like, first thoughts, what do you think's happening? So I have a P for every QRST complex, but something just doesn't look right. If we think back to our normal sinus rhythm and our normal intervals, do any of these look weird? Yes, this is our first degree heart block. Our PR interval is definitely longer than normal. It's definitely greater than that 0.2 seconds. So for this one, usually cardiac medications are the cause, possible vagal nerve stimulation, etc. How you differentiate this is our P wave. Our P to R interval is increased. That's how we diagnose first degree heart block. So what are we going to do? We just monitor our patient for symptoms. All right, what's this one? Oops. Well, there we go. Anyway, it's AFib. So this is like the atria are quivering. With AFib, it's just got a really irregular rhythm. If we kind of go back to it, the atria are quivering. There's that loss of atrial kick. So our atrium aren't effectively squeezing. Something's going on. Our P waves for this one are kind of indiscernible. But how you also diagnose AFib is look at our R to R interval. Our R to R interval is not equal. There's a different amount of space between each peak of the R in our QRS complex. That's pretty indicative of AFib. So what I'm concerned is my patient's going to have an increased heart rate. But of course, I'm going to assess them. What am I going to assess them for? Symptoms of hypoxia. So are they fatigued, dizzy, short of breath? Are they tachycardic? Are they telling me I feel like I'm having a million palpitations? That's really what we're going to look out for. So again, our major concern for AFib. What is our number one concern for AFib? It's a big one. Why is AFib very dangerous? Yes, clots. AFib puts our patient at risk for clots. Also, the poor perfusion is an issue, but with AFib in specific, I'm really concerned about clots because my atria have lost their kick. So they're not effectively squeezing all of that blood that is stuck in that atria. So what's going to happen? There's going to be blood stuck and left over in the atria. What happens? It's going to pool. It's going to clot. And then what happens if it gets pushed out into systemic circulation? My patient might have a blood clot. They might have a DVT. They might throw a pulmonary embolism. So I'm really concerned with clots. So how do I treat this? If they're in the hospital with me, I'm going to start them on a heparin drip. Once that's working, maybe switch them to a low molecular weight heparin. And then I'm starting them on warfarin. Why? It takes a little bit to start working. So when they go home, they're going to be on warfarin, aspirin. So what do I as a nurse need to do? I need to teach them about bleeding precautions. So that's a big one too for your nursing considerations. All right, I promise guys, one more rhythm. What in the world is this? What's happening? These look very weird. What do you think's happening? Yep, my patient is throwing PVCs. What are PVCs? These are our ectopic beats. What's concerning about ectopic beats? These are non-perfusing beats. So if my patient is having maybe 1 or 2, they still might be perfusing. But if these are having back-to-back, like shown in the picture, how we have 1 normal beat, then a PVC, then 1 normal beat, then a PVC, all these PVCs, they're non-perfusing beats. So what am I concerned about? Now I'm really concerned about hypoxia. Now I'm really concerned about low perfusion. So this one, QRS complex, is bizarre and all over the place. So our bigeminy versus our trigeminy. This photo shows bigeminy. This is every second beat, my patient's throwing a PVC. So again, really concerned for perfusion. So assess my patient and assess them for signs and symptoms of poor perfusion. This is really common in heart failure if someone's having an MI, angina, electrolyte imbalances, drug toxicity. Keep in mind, back from patho, any issue with potassium can cause electrical chaos because potassium pumps the heart. So now we're going to get a little bit into systemic disease. So let's first talk about our peripheral vascular disease. So this occurs when that oxygenated blood pools in the extremities. It has a hard time returning up. So there's 3 main categories of PVD, or examples of PVD, I should say. So really review, what is our VTE, our venous thromboembolus? What are our varicose veins? And what is our venous insufficiency? So I would definitely recommend just reviewing the basics of those. For all of these, though, really our sedentary lifestyle, females, family history, frequent standing, especially for our varicose veins, and our Virchow's triad, our VTE, are all components. And on the next slide, I go over VTE, so don't worry. But what are our signs and symptoms? Think of the signs and symptoms associated with blood pooling in our legs. This blood is staying in our legs. So I'm going to have big bounding pulses in my lower extremities. My legs are going to be really warm. Why? All of that nice warm blood is pooling in my feet. I'm going to have the edema, irregular shaped sores from that skin expansion. They're going to have like a dull pain. And then yellow-brown swollen ankles. You can kind of see the signs and symptoms say veiny. I just thought that might help you guys remember a little bit more. So what are my laboratories? I'm going to have an elevated D-dimer, and an elevated ABI. It should say above 1.2. So just kind of keep that in mind. But just know that they're going to have an elevated ankle brachial index. Why? Because their feet are very swollen, their legs are very swollen, their ankles are very swollen. I'm going to have a very quick capillary refill because I have a lot of blood in my toes. Really though, what am I concerned about? All this blood keeps pooling. Like we said with our PVCs, when blood pools, it likes to clot. So I'm concerned about blood clots. So before we move on, I just threw in a little bit of information about Virchow's triad. I know I covered this in pathophysiology. I took the slide from our midterm review from patho. So just for your convenience, but knowing this puts our patient at risk for VTE. So yeah. And also, any patient in the hospital is at risk for VTE. Why? A lot of them aren't moving. A lot of them have vascular wall injury. They have IVs, they've had shots, etc. So anyway, our medical treatment, we want to prevent our pulmonary embolism. We can also give unfractionated heparin. That's our Lovenox shots to help with clots. Really, we're going to focus on blood clots. So if there is a clot, we can give them clot busters. But again, really the goal for treatment, prevent clots. And what are we going to do? We're also going to elevate our legs if they have a venous issue. Why? It can kind of help that blood. If we elevate our legs, it can help the blood return to the heart. So really teaching your patient, don't cross your legs, wear compression garments, increase walking, elevate your legs, etc. So again, review your DVT prophylaxis as well, because I think DVT is really important. And if any of them were to be tested upon, I think DVT would be a big one, definitely. Also, monitor your APTT for heparin and have your antidote on hand. So go back and review your pharmacology for that. On the other hand, we have a peripheral artery disease. So our blood has a really, really hard time getting down. Why am I concerned now? Inadequate blood flow to my lower extremities. So patients with these will present with no symptoms at first, but then it can progress to our intermittent claudication, which is our pain during movement, and it stops at rest. But then if it keeps progressing, they're going to have pain at rest, and then guess what? Necrosis, gangrene, etc. So I would educate your patient on looking at their risk factors and how we can modify these risk factors. Smoking, hypertension, hyperlipidemia, obesity, big ones. I would know your 6 Ps for this one, and really knowing that the symptoms associated with PAD are symptoms that are caused by lack of blood flow, lack of oxygen. So that's why they're going to have shiny mottled skin, ischemic ulcers, brittle toenails, red round sores, dependent rubor, etc. So they're going to have a decreased ABI of less than 9. Why? Because their ankles are going to be skinny. In the lab, in the exercise lab in the hospital, they can do exercise tolerance testing for that intermittent claudication, etc. But we looked at the risk factors. What do I want to do? I want to really teach my patient how to prevent chronic stable angina, MI, and stroke. So what can I do for these patients? Don't focus too much on the surgery. I would focus on just really our antiplatelets to help the blood flow to the lower extremities a lot easier. You can give them your vasodilators, your Silostol. What do those do? They're going to, again, help promote blood flow to the lower extremities. We're going to give our statin drugs because we know that CAD and hyperlipidemia is a big causative factor, so kind of working on those. Really, we want to promote vasodilation and prevent vasoconstriction. This is why we don't have them soak their feet in anything cold, because that's going to cause vasoconstriction. We also want to prevent compartment syndrome as well. So teach these patients, keep your legs dangled. Don't have them wear stockings or scads because that's just going to cause further compression. And for these patients, we don't want them to raise the legs. Why? Because we need it to get down. We don't want it coming back up. And then if your patient's experiencing intermittent claudication, have them walk until there's pain, have them stop, and then encourage them to keep going. This is really what's going to benefit them. So I just put a little slide here again for your convenience. So the last thing we're going to talk about today is our anemias. It shouldn't take much time, but for you guys, I'd focus on knowing your normal hemoglobin, hematocrit, etc. And what's the big deal about chromic versus cytic? So I put in this nice little slide for you guys just to help, but really our anemia labs, we run a lot frequently in the hospital. Our MCV, this measures the size of our red blood cells. So this is what our cytic is. Is it normocytic, microcytic, or macrocytic? Our MHC, that measures how much hemoglobin is in the blood. So is it going to be normocytic or normochromic, meaning normal amount of hemoglobin, or is it going to be hypochromic, meaning a decreased amount of hemoglobin? Our MCHC, this compares our hemoglobin to the relative size. So with our nursing for anemia, really we want to recognize signs and symptoms of those pallor, confusion, etc. We want to do a nutritional evaluation on these patients to see what might be causing it. We want to make sure, can you tolerate activity? These patients might be on fall precautions. Monitor their pulse ox. Why? Hemoglobin helps carry blood, helps carry oxygen to the blood. So if we don't have a lot of hemoglobin, I'm concerned for inadequate oxygenation. So monitoring that as well. Usually these patients, it can be corrected with nutrition. However, they might be on certain medications, and just teaching them to follow up with their doctor and follow up on those meds are going to be really important. So let's talk about iron deficiency anemia. This is going to be our most common type of anemia. It's usually going to be caused by blood loss, hemorrhage, bleeding, and lack of inadequate iron in the diet. But really focus on those excessive blood loss. So these patients are going to have microcytic and hypochromic anemia upon lab value, because they just don't have much of anything in this case, especially if the cause was a bleed. They're going to have decreased everything. So what are some signs and symptoms? Pallor, glossitis, cheilitis, postural hypotension, those spoon nails, pale ears, etc. So know your assessment. What am I assessing for? Medical treatment, we treat the underlying cause. If it's hemorrhage, we might need to give them RBC infusions. Iron dextrin injections help as well, but most of the time we're just going to encourage them, if it's a dietary issue, provide them with dietary nutrition, connecting them with a dietitian, etc. So some nursing considerations. Usually these patients will be on supplemental iron. So what do we tell a patient if they're on supplemental iron? And just things like that. And they're going to need a follow-up on their labs. Aplastic anemia, though, this is going to be caused by our pancytopenia. Is ferrous the one that causes constipation? Any sort of iron supplement will cause constipation. It will also cause the patients to have like a tarry black, sometimes green stool. So just letting them know to increase fluids, fibers, fruits, and to also maybe take a probiotic with the iron. But like any supplemental iron, whether it be Ferritus, Iron Fe, like anything iron related will cause constipation. So for our aplastic anemia, this is caused by an issue with our bone marrow, and it's not producing any of our vital blood cell types. Usually it's going to be caused by cancer, autoimmune diseases, or chemotherapy. Our patients are going to have normochromic, normocytic red blood cells because their red blood cells are normal. It's just that they're not producing as much as they should be. So that's why it's going to physically appear normal, but they're just going to have drastically lessened amounts and pancytopenia. So what are some signs and symptoms? Well, because they have decreased everything, a lot of infections, neutropenia, fever, bleeding problems, thrombocytopenia, they just have less than what they should need. So for these, we treat the underlying cause. If possible, they might require a blood transfusion. If it's an immune process disease, immunosuppressants. You can give them either IV or SQ or erythropoietin alpha. So that's going to be pretty important for this one. And then after the injection, watch that patient's blood pressure because E alpha can have an effect on their blood pressure. So for these patients, they need to frequently get their lab values checked out. Unfortunately, patients with pancytopenia are just very sick. Our pernicious anemia, this is the body's, it's caused by our body's inability to absorb B12. So in order for us to take in iron, we really need to have an adequate amount of vitamin B12. So possible causes, honestly, anything that involves the intestines and the absorption of nutrients can lead to pernicious anemia. It's not associated with our diet. Our body just physically can't absorb B12. So our laboratories, they're going to have macrocytic anemia and increased MCV, etc. Don't pay too much attention for your pernicious anemia, your labs, your signs and symptoms. Really focus on your medical treatment. So for these, I need to supplement what I'm missing. I need supplemental B12, probably for life, and then just making sure all of my other medications are up to par. Our folate deficiency anemia, let's break it up real quick. Folate. What is folic acid? Folic acid is vitamin B9. Vitamin B9 helps us make new red blood cells. So if I have folate deficiency anemia, this usually occurs with our slower, insidious onset because we're just really deficient in vitamin B9 and folic acid. So what's our cause? Inadequate folic acid, poor nutrition, alcoholism, pregnancy. Pregnant moms need more vitamin B12. Again, laboratories are going to be macrocytic. Signs and symptoms, weight loss, malnutrition, just think emaciated. Medical treatment, again, back to the anemias, you give them what they don't have. Folic acid, we want to increase folic acid foods. So I would review nutrition. What are our folic acid foods? Organ meats, greens, citrus fruits, whole grains, beans, etc. And then for nursing considerations, this would be your education, educating your patient on why it's important to take folic acid. Folic acid works with vitamin B12 to help our RBCs. So if my patient has folate deficiency anemia, going back to this slide, pernicious anemia, they might be at risk for pernicious anemia. Or if my patient has pernicious anemia, they might also have these issues with their folic acid because the two kind of work hand in hand. So just kind of keeping that in mind. So yeah. And I believe that is all I have for you guys. I do apologize for having to rush through this. I didn't want to keep you here super long. I'm going to go ahead and stop the recording now. Real quick. And while I work on that, again, I'll be uploading your guys's Complex Health 1 exam review, and just making sure you have all of that ready to go. That should be uploaded